Good afternoon. Thank you, Scientific Committee, for giving this opportunity. Today I'm going to talk, my slide is automatic going on. Yeah. So today I'm going to talk about tonito microhook trabeculotomy, and apart from this, a newer goniotomy. So as the Dr. Amit has already talked about the KDB and the bank procedure, so I will limit my talk into the microhook and what the newer goniotomy, what was in the trial. So as we know, goniotomy is not a new procedure. It has been time tested for the congenital glaucoma. Look for the 1936, Otto Barkan has done the goniotomy for the congenital glaucoma. So what's the problem with the older goniotomies? They call the incision goniotomy. Here we just make the incision. And what happens, this leaflet will be the joint and the scar. So what happened? Again, the IP become high. Now the newer goniotomies, like newer goniotomy called the excision goniotomy, that can be done by either the KDB or by the KDB bang or by the tonito microhook. So in this, what happened? The leaflet is quite wide, and this quite collected cilium canal, back of cilium canal is quite widely open. That flap will not fuse and will sustain the IP control for longer period of time. Various studies have shown the excision goniotomy produced a significant IP control. As already Dr. Amit has told, really the boom toward the MIGS surgery, it's a lot of world is going toward the MIGS surgery because they're very effective, less automatic, and produce the very fast recovery. And this is the way we also changed from the last 3 to 4 years. Our most half of the surgery is going to the MIGS only. So now coming to the first trabeculotomy, tonito microhook trabeculotomy. These are the simple instrument, the Sinski kind of instrument. So what do within this procedure? In this we cleave the trabecular meshwork and inner wall of the cilium canal and make the direct communication between antechamber and corrector channel. So these instruments are the right-handed, right angle, right angle, and the left angle, and it's one of the straight incision. So look for this tonito microhook, this last fourth corner here. So I'm sorry. So the last fourth corner here is a tonito microhook. It is a simple Sinski kind of instrument. So anybody can have these are the other instruments, they're quite bulky, they're big, but this is a very simple instrument. All the phacosurgeon can perform these surgeries. And beauty of this procedure is this, that apart from the gate, this is the only procedure where we can target more than 180 to 240 degree of the angle. So coming to the indication, I think what the indication, Dr. Amit told similar indication to all the MIGS surgeries, some contraindication like the universal glaucoma, phakic, advanced glaucoma, and ocular inflammation. And this is the video is showing how the tonito microgoniotomy is performed. This is the right angled tonito microhook where we can use to the supranasal angle has been incised, and with the left tonito hook infranasal angle has been incised, and one more the straight incision also will be there. I will show in my surgery. So this is again similar way, form the after phacoemulsification, use the Swan Jacob gonio lens as Dr. Amit already told, and just incise the trabecular meshwork. So with the left hand side you can incise the inferior angle, then again come to the right hand side. Right hand side you can use the angle. Similar way, and you can see this right now is the white snow only structure. This is with the use of this. Again, if you want to do the more goniotomy, you can the patient head inferiorly, or you can make the other side. Tonito microhook. I'm sorry. So end of the procedure. So once you do this, form the AC little tighter inside, because sometimes the mild hypema or bleed may be there. Or you can check, you can inject the blue. You can see some of the blue is coming through the aqueous veins. You can see the on table your surgery is working beautifully. Then certain situation like in glaucoma, especially with coming with this, let's say iris glaucoma, high IOP patient having the glaucoma, really any glaucoma surgery is very, very challenging in such situation. So doing the trap or the tube really is very challenging. So in such scenario, this is the tonito microhook very easy to do. Similar way what I showed in the previous video. Similarly, you can take the make the AC little tighter inside. So we did one study where they randomized control trial of the 57 patients in each arm in phaco-tenito group versus phaco group. So in phaco-tenito group, IP reduced from 26 to 12 mmHg at the end of 12 months, while in phaco group 25 to 20. And look at the anti-glaucoma reduced from 0.6 to 0.2 in phaco-tenito group, while 1.4 to 1 in the phaco group. And there is no major complication except from the sum of the hyphema. And the various studies shown the efficacy of Tenito microhook. Why we choose Tenito? Because very easy to perform, economic, efficacious, have good safety profile. I had chance to meet the inventor of Tenito microhook. Apart from the some newer goniotomy procedure, they are like the absolute juxtacanalicular space goniotomy. This specially designed instrument, the taper in this tapered is tapered end, it is a blunt end. So it's give the there's no risk of you can damage the ciliary body or scrape the DM, and this is the only 60-degree nasal goniotomy has to be done. So I'll show this the procedure. So this is the absolute Tenito, absolute hook. So what we do in this procedure, we do the minimum damage to the tissue. So this the hook goes into the Slam's canal. Here we just scrape the trabecular meshwork. We are not removing it, scraping and keeping into the there only. So what we doing, just we are bridging canal, open canal with the TM itself. Similarly, and the area of treatment is much lesser than any other procedure. Similar way we can do in the superior nasal side at the end, similar to the any other procedure we can do. So we compare the outcome of the I think this is another study by the S-pilot itself, and show the IP control 38% at 12 months, 35% at 18 months, and 31% at 24 months. So we did the comparison of phaco bang versus phaco absolute, and we find the phaco bang and phaco absolute almost have equal IP control at the end of the 6 months. And in the interesting part is that in absolute group, AGM use is much less in compared to the bang. This is again the new goniotomy, interventional valve enhancing trabeculotomy. In this we use the specialized instrument. So it's not available right now, it's in trial phase. Here we create the tiny vent at the anterior outflow tract. So what we are doing, what basic advantage of this procedure, we are not damaging the trabecular meshwork. We are making the incision at the level of salvage line. So what will happen, it will enhance the pulsatile outflow of the aqueous flow. So it's a less atraumatic procedure. Probably in the future I can show some result. I am currently working on it. Then coming to the another process called the gonio scrubber, because we want to minimum disturbance to the tissue. So this is the new process called the gonio scrubber. What we do here, we just scrape the dirt of the trabecular meshwork by using a diamond knife. So instead of diamond knife, we form a special instrument. So this is the instrument what we use to just clean the trabecular meshwork. So I'll show in the video after doing the phacoemulsification. This is the case of the phacoemulsification, and I will show the instrument. This is from soft instrument. You can see it's so gentle, and similarly we have to do the just clean on the trabecular meshwork. This process is very effective, especially in students who initially studies glaucoma, anti-glaucoma, open hypertension. Because we are not doing anything, just we are sweeping on the trabecular meshwork. So it's called the medicine trabecular activation, tissue activation, and it's clean the trabecular meshwork as well as the increase the outflow. Rest of the process similar to any other device procedure, was in thoroughly surgery. So just to conclude, neurogoniotomy seems to be promising, being an implant free with minimal damage to the typical tissue meshwork and relatively easy learning curve, and have the minimal complication. Thanks for patience listening.
Nice presentation.
Thank you, sir.
What is the efficacy of gonio scrub?
Gonio?
Scrub.
Gonio scrubber is still an under trial. Is very helpful in few certain type of glaucomas, especially in pigmentary glaucoma and studied glaucoma. So I can't comment on it right now. There's a trial phase.
What is your initial experience?
Initial experience, it reduce the IP. They come into the high teens. They don't come into, suppose IP is 24. So it reduces to 15 or 16. We don't get the very good IP control like other goniotomy we got.
From where you're getting Tenito and Espilate, hooks and source and cost.
So Tanito, I have collaboration with Tanito and a company who manufacture it, Inami and Raiko. So I am working with them. So I have
Anybody in
access.
India selling it?
Probably we are launching soon. Probably in next AIOS we launch the Tanito here in India. Yeah.
What is the name?
Land hook. And you can get the Tanito by Inami. Inami is distributing, but they unfortunately they not is distributing in India. If you go to Southeast Asia, Thailand, Malaysia, even China and Indonesia, Japan, South Korea, they all are supplying. Inami is supplying the Tanito Micro. They have some issue with approval, so probably they are coming soon in India.
Very good.